You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape in Discussion Psoriasis. I'm your host, Dr. Steve Feldman. This is episode 2 of this year's 6-part series on psoriasis management, and today we'll focus on 3 important comorbidities for individuals with psoriasis: cardiovascular disease, psoriatic arthritis, and mental health issues. We have a lot to cover. This is going to be a lightning round with 3 guests. We'll start by delving into how cardiovascular disease and psoriasis are linked. Many people may think of psoriasis as a cosmetic skin disorder, but it's an inflammatory disease with considerable internal impact. With me for the cardiovascular portion of this discussion is the former NIH Section Chief of Inflammation and Cardiometabolic Diseases and the founding principal investigator of the largest cohort study examining psoriasis impacts on cardiometabolic disease to date. He left the NIH to pursue his work on an international scale and is clinical professor of medicine at George Washington University in our nation's capital. He has cross-linked the fields of cardiology and dermatology by publishing results of several studies on how psoriasis impacts cardiometabolic health. Welcome, Dr. Drs Mehta. Welcome, Nihal.
Steve, it's great to be here. Thanks for having me. I'm so excited to talk about all of the research as well as clinical implications of cardiovascular diseases and psoriasis.
Yeah, the work you've been doing is absolutely groundbreaking, maybe is the hottest area of research in dermatology. Let's start. What is the relative risk of a major adverse cardiovascular event in people with psoriasis compared to the general population?
So there's a couple good studies, observational databases that show that if you have severe psoriasis, you have about a 50 to 60% increased risk of heart attack, stroke, and dying from that heart attack or stroke. If you have mild psoriasis, that number is anywhere between 10 and 15%. It's a real risk factor.
One of the things that I look at when I'm reviewing manuscripts is trying to figure out what the absolute risk is when somebody tells me, oh, there's a big relative risk. I know that the work that came out of the University of Pennsylvania using the Great Britain's research database saw that if you had severe psoriasis and you were between the ages like 20 and 30 years old, you were like at a 2 to 3-fold increased risk of having a heart attack, which sounds terrible until you think that, well, the baseline risk of a 20 to 30-year-old having a heart attack is roughly 0. 2 to 3 times that isn't so much. So what is the absolute risk that we're talking about?
It varies by age, Steve, and I'm glad you brought that up. In fact, the more severe the disease is, the younger the patient is, the more the absolute risk is higher. Now, you're correct. The absolute risk may not translate into a clinical event, but the cumulative risk of that does take some time. So numbers, if you're between 40 and 50, the relative risk is 1.47, so 47% increase if you have severe psoriasis. So that's a real number. It's 1.47. Nothing relative about it. It's an absolute risk. If you look at that compared to an 80-year-old where the risk of age is now higher, the risk of psoriasis is actually lower. It's about 20%, 1.2. So age matters a big deal. But my message to you, my message to the listeners is the younger you are and the more severe the disease is, the more it impacts your cardiometabolic health.
These patients are often seeing a dermatologist. Dermatologists, we don't normally do EKGs, or we don't even measure blood pressures on people most of the time. What cardiovascular screening should we be doing for our psoriasis patients?
There's 3 things. I call them the Mehta 3Bs. You should get your body mass index checked, you should get your blood pressure checked, and you should get your blood checked for glucose and for your cholesterol. You'll find that starting at the first diagnosis of psoriasis, if one is educated that there's a risk of high blood pressure and the risk of obesity and the risk of high cholesterol, it's easier to talk about the risk of heart attack and the risk of stroke. So first diagnosis, and then every 5 years thereafter, a patient should be screened for these 3Bs. And yes, it should start in children. We have compelling evidence in not one, but 2 studies that insulin resistance and obesity start very early on in children with psoriasis.
I get the sense that these 3Bs are probably the most important screening that we should make sure gets done, but it's not the sexiest. The sexiest thing to us dermatologists would be if treating the psoriasis would reduce the cardiovascular risk. Does it? I mean, psoriasis is an inflammatory disease, and it's the inflammation that's causing the risk, right? So if I get rid of that inflammation, maybe I reduce the cardiovascular risk?
Steve, you would hope so. And the answer is we're still dissecting that, but you might wonder why a cardiologist is in this field at all. Well, I was using psoriasis as an example, as a model disease to say, hey, if you have inflammation, you can see, and in fact, you treat it, and that inflammation goes away. Will, in fact, your cardiovascular or cardiometabolic diseases get better? And we have dissected this out over a 10-year period of time in our cohort study. And what we have found is 3 things. Treating the disease is important. It reduces systemic inflammation. It curbs insulin resistance due to the reduction in systemic inflammation, and thereby diabetes and metabolic syndrome, as well as obesity itself, will improve. The third one, and the biggest one, is there's anecdotal observational evidence through databases as well as some of our own observational work. You treat the disease if it's severe, and you drop its severity down to mild over as small as 1 year period of time, you will see an improvement in both subclinical atherosclerosis as well as the age of the artery through vascular and coronary inflammation. We have not done a randomized trial showing that treating the disease is improving cardiovascular outcomes, but there is time to do so. My message would be that treating the disease is important in improving quality of life. Treating the disease is important cosmetically. So even though we don't have the magic bullet yet for cardiovascular itself, we do have quite a lot of evidence that keeping this disease, once thought to be cosmetic, at bay is extremely important for other comorbid diseases.
I'm wondering about absolute risk again. So I'm old. I got high cholesterol. And my preventive cardiologist said, Steve, take a statin. So I looked at the risk calculator. And if I take my statin regularly, I can reduce my cardiovascular risk of having an MI over the next 10 years by like 30%, which sounds like a lot until you look at the baseline risk is 7%, and the 30% reduction takes me to 5%, 7% to 5%. So even if treating the psoriasis was as potent as a statin, that's the kind of numbers we'd be looking at?
That's a great analogy, Steve. And I think that is exactly how I explain the impact of what we have seen on the treatment of severe psoriasis with biologic therapy on coronary inflammation, non-calcified burden, and most recently, lipid-rich necrotic core. It's approximately 8 to 10%, which is about what a statin does. Yes, you're right about the relative risks being larger, the absolute risks being smaller, but it is also 2% of a risk reduction in a steep curve. So it depends on where you want to take your risk points, right? So here, if there's something that you can do to reduce something 2% points, I would do it. Cardiovascular epidemiology has always thought that 2 to 5% of a risk reduction is very important for absolute risk prevention when you look at a population level. So I think that the statin that you're taking, you should keep taking it. And I think people should treat their skin disease and take it seriously in psoriasis.
You know, I get the sense, just to summarize it, this is kind of like the retirement money match that you get. It's like free money because you want to treat the psoriasis, as you said. You want to get people well, get their skin cleared up, get rid of the itching and the cracking, the pain, the misery, the social implications, make their joint pain go away. And you get all that by doing the treatment, plus the free money of benefits of cardiovascular improvement. Now, thank you so much for your time today.
Steve, thanks for having me.
Now we'll shift the lens to psoriatic arthritis. How prevalent and impactful is psoriatic arthritis as a comorbidity for psoriasis? Should we be screening? What's the best way to screen? To answer these questions, we have the director of the Clinical Immunology Research Unit and the principal investigator on clinical trials testing the efficacy of anti-TNF agents and other biologics in the treatment of psoriatic arthritis. He also has a research lab where he spends most of his time. He's professor of medicine at the University of Rochester School of Medicine and works in its Division of Allergy and Immunology and Rheumatology at the Center for Musculoskeletal Research. He is Dr. Christopher Ritchlin. Welcome, Chris.
Thank you, Steve. It's a pleasure to be here.
We did some research on our psoriasis population years ago, and we found, using the short form 36 as a general measure of quality of life, that the quality of life of patients with psoriasis was reduced more than diabetes, hypertension, heart attacks, believe it or not, even cancer. This was a highly cited paper in the dermatology literature. Most of that physical impact was actually caused by the arthritis that is associated with psoriasis. How common is arthritis in patients with psoriasis?
Well, if you take patients across the board, the prevalence is about 25 to 30% of patients with psoriasis will develop psoriatic arthritis. And as you know, typically the psoriasis precedes the onset of arthritis by several years. So it's quite prevalent. And as you've mentioned, and I know your paper very well, I've quoted it, it really has a major negative impact on quality of life and function for patients. So it's a huge comorbidity in terms of how it affects patients and how they live.
Yeah, there's this dogma that the psoriatic arthritis comes after the psoriasis. I'm sure many times it does, but I've often wondered if the psoriatic arthritis might occur before the psoriasis just as often, but when that happens, it's hard to know that it's psoriatic arthritis. It might get called something else, seronegative rheumatoid arthritis or something, just because it might be hard to make the diagnosis of psoriatic arthritis if there's no obvious psoriasis there.
Happens all the time. We see it quite commonly, and that's why it's well known. And a recent study was at our national meeting 2 months ago that looked at the comparison between rheumatoid arthritis and psoriatic arthritis, and I'll call psoriatic arthritis PsA, much delayed compared to RA diagnosis, and therapies introduced much later and to a much lesser degree for similar burdens of disease. So this is a major issue. The other thing, and Nihal knows this very well, is if you image psoriasis patients who have no musculoskeletal pain, you find all sorts of things in their musculoskeletal system. In terms of bony changes, some subclinical, I say subclinical because they're not having symptoms, but they have evidence of tendinitis, there's arthritis in some of these patients on imaging. So I think that a lot of psoriasis patients out there who are not diagnosed with PsA have ongoing musculoskeletal inflammation.
Years ago, I asked an interested rheumatologist what we dermatologists should do to screen patients for psoriatic arthritis. And I think the bottom line was they said ask about joint pain, joint stiffness, back pain, and fatigue. I'm not going to ask about fatigue. What were your recommendations to other physicians for how the non-rheumatologist should screen for psoriatic arthritis in psoriasis patients?
I think those are the recommendations you just quoted we made several years ago. And I think that more recent work from Leahy Eder at the University of Toronto showed that actually fatigue was an early symptom of psoriatic arthritis and very prevalent in those patients who went on to develop PsA. So I think fatigue is important. Now, obviously, the other reason is a lot of our patients are heavy, as Nihal mentioned, and a lot of them have sleep apnea, and there's other things that can be leading into the fatigue, but it's very important in arthritis. And the other things you mentioned, which are joint pain, stiffness, and back pain. 40% of patients with psoriatic arthritis will have involvement of their SI joint or spine, and many of them are not necessarily symptomatic when you see them. However, the presence of back inflammation dictates a certain kind of therapy because there's some medications that work for that and others that don't. So it's important to know whether your patient has inflammatory back pain in the setting of psoriasis.
I like to think that these screening questions are all I need to do to screen for patients. And if I get positive results, I'll have a very high sensitivity for detecting the psoriatic arthritis. Do you want me to be doing any kind of physical exam as well as part of this screening process?
I think that's a lot to ask for dermatology to do given the burden of your day. I work in a combined clinic with here in Rochester with dermatology, so I know. There have been several questionnaires that have been published that are for psoriasis patients to elucidate whether they have a risk for psoriatic arthritis. I think that's probably a better way to go in terms of trying to screen. And you can have them do it in the waiting room so it's not impinging on the time that you have with them. Then your assistant or nurse can score it and then flag it and say, since he scored or she scored above the threshold, we might think about a referral. I think that's a better way to do it.
Yeah, I have the impression that if somebody did have any kind of arthritic symptoms, the basic physical exam that would be needed would be a complete musculoskeletal exam, including range of motion and evaluation of gait. And I'm not going to do that.
Exactly. What our dermatologists do, though, if they get a hint there might be joint pain, they'll go ahead and order serologies and actually order x-rays. So by the time I see them, that's all been carried out, and it really speeds things up considerably. And these are people clearly are having arthritic symptoms. So it's not like there's people that don't clearly have a story that's consistent with arthritis.
So I wouldn't know what x-rays to order. What x-rays should I be getting?
Generally, hands, feet, low back.
Hands, feet, and AP pelvis.
That shows you the SI joints.
I'm going to write that down. So we're going to screen. We're going to find these patients. Is it going to make a difference in their long-term outcome?
Study published several years ago in Ireland showed that even a delay of 6 months of initiating treatment had a major negative impact on outcomes. It was surprisingly quite a negative impact. So yes, timely diagnosis can improve response and outcomes.
Super. So to summarize, the take-home message is the joint involvement in psoriasis has a huge effect on patients' lives. We want to catch it early. I don't know if you have to catch psoriasis early, because if we treat it, the skin appears to go back to normal. One of the things I love about being a dermatologist, but the joints, you can get permanent destruction. So screening, getting somebody to treatment early is valuable.
Absolutely. And then the other question that we're studying now is whether or not early intervention to treat psoriasis can lower the likelihood of developing psoriatic arthritis or decreasing the severity. And so there have been 3 studies published this year that looked at different databases. The problem with the databases is an inherent bias that we can't control for. And also a lot of the coding for PsA is not what we would really like. And so we're now doing a study where we're intervening in patients who have abnormal ultrasounds and no musculoskeletal symptoms who have psoriasis, and we're treating them with placebo versus on a biologic agent, and the outcome is the development of psoriatic arthritis. So hopefully in a couple of years, we'll have some answers to that question.
That's extraordinarily exciting. Chris, thank you so much for being on with us today.
Thank you, Steve. Pleasure.
Now let's shift to mental health and psoriasis. To discuss this highly relevant and timely topic, we have an internationally recognized researcher and teacher. He's a board-certified dermatologist and clinical psychologist who I've known for years. He's known for his compassion in the clinical arena, the author of publications on psoriasis, acne, rosacea, aging, and the psychological benefits of skin enhancements. I present Dr. Richard Freed. Welcome, Rick.
Hi, Steve. Great to be here.
Yeah, it's such a pleasure to talk with you. Before we had treatments that cleared psoriasis, I think patients needed empathy more than anything else. With your expertise in both psychology and dermatology, how do you see the impact of psoriasis on patients' lives before and after their treatment?
25 years ago, when I first entered the field, I knew psoriasis was a big deal. As years have gone by, it has become more absolutely clear that psoriasis has a protean impact on all spheres of the human's functioning. Our work, our play, our intrapsychic lives, and our sexual lives. Often that impact is directly correlated to the severity of the illness. Just as often, it is not, and even the smallest amount of psoriasis can have devastating impact. The impact is sometimes very evident. People say, I'm depressed, I'm miserable, sleeping all the time, I'm not sleeping at all. Often, though, it's subclinical. They do not realize how much psoriasis has stolen from them, how much of their happiness, their energy, their engagement. It's an insidious loss, happens slowly. Only after treatment do patients realize how much psoriasis had cost them. It really can be a wonderful experience as they gain back the lives that they've lost. Many patients just don't know what steps to take, and because they're not really conscious of how much they become debilitated by psoriasis, sometimes it takes a bit more prodding to get them to move forward with legitimate therapy. And that's something we can do in a very, very efficacious and very safe way with our modern tools.
So with these great new drugs we have, injectables, new orals, we're able to get psoriasis patients clear to an extent that we never used to be able to get them clear. Now that I can do that, do I still need to be empathetic?
Yes, because empathy goes a long way. And psoriasis robs people of control. They feel out of control. It's capricious. It does what it wants, when it wants, where it wants. So being empathic, simple empathic statements. I very, very much understand and appreciate how difficult it is to live with psoriasis. I'm committed to doing this together and taking you to where you want to and need to be. Being empathic, saying, hey, I don't want to tease you either. I mean, if you've had psoriasis for a long time, you've been teased with this for a while, saying, my tool bag is incredibly deep. I will not stop until we get you where you want to go, and we will take you there safely and comfortably.
I feel like I'm pretty good at seeing psoriasis, making the diagnosis of psoriasis, and choosing a treatment based largely on the objective skin findings that I see. But what kind of psychological screening should I be doing as well?
I think when it comes to assessing psychological impact in the office setting of the non-mental health professional, I think the physician health questionnaire, the PHQ-2, is a quick, effective instrument, and it simply asks two questions. Number one, little interest or pleasure in doing things, and number two, feeling down, depressed, and helpless. Those are two very poignant and I think helpful questions. The second is what I call the 3-second eye test. One of the things that we all learn from our nerdy beginning is that if you maintain eye contact for more than 2 or 3 seconds, you are either coming on to someone or challenging them to battle. So particularly with my male patients, I'll look them in the eyes and say, tell me something, Joe. How difficult is it to live with the psoriasis? After 2 or 3 seconds, the tears start to well, and almost invariably, I hate it, Doc. Women as a group are more forthcoming. After 2 or 3 seconds, they say, here's what is robbing from my life. So I don't think it has to be long, standardized assessments. Make them think, make them feel, give them a solution. Making them think. Have you lost interest in pleasure? Do you feel helpless sometimes? How burdened are you? How does that feel? And here's our solution, because we can together move forward in giving you the control over psoriasis that you need and that you want.
But there may still be some patients that need more than that. When do I need to refer patients on to a mental health professional?
It's a great question. If it's obvious that these patients are more distressed and suffering more than the simple, quote, empathic statements are able to manage, then the next step can be very useful and quite simple, actually. There's something I refer to as a skin emotion specialist. These are psychiatrists, psychologists, social workers with special interest in skin disease such as psoriasis, who know that straightforward techniques can be very helpful in making people feel better, function better, and in fact, making their treatments work better. These include things like mindfulness meditation, CBT or cognitive behavioral psychotherapy, straightforward techniques that can make their physiology and their emotional world much healthier.
Rick, thanks for speaking to us about these mental health issues. Patients may not be aware how much psoriasis is taking away from their lives. When we treat patients with psoriasis, they are experiencing such a tremendous benefit that we should feel really good about what we're doing for people, both for their physical and mental health. Being empathetic is a helpful intervention beyond the great treatments we have, and we should be on the lookout for people who need more than that. Rick, thank you so much.
Steve, always a pleasure. Thanks so much.
Thanks for joining our discussion on psoriasis comorbidities with Dr. Nihal Mehta, Christopher Ritchlin, and Richard Freed. In the next episode, we will be discussing the important issue of how to control limited psoriasis. So important because the vast majority of people with psoriasis have only limited disease. Our guest will be dermatologist and researcher Dr. Kim Papp. Dr. Papp has tremendous firsthand experience in studies of psoriasis treatments. So be sure to look for that next month on the Medscape app, medscape.com, or other major podcast platforms. I'm Dr. Steve Feldman for Medscape in Discussion. Thanks for listening.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on psoriasis.